So it's my pleasure to sit here with a few of my esteemed colleagues who are experts in dermatology in skin of color. And today we're going to be talking about psoriasis. Now, psoriasis is one of the most common inflammatory skin disorders that we treat as dermatologists. And in fact, it affects about 125 million people worldwide. But there are common misconceptions about psoriasis when it comes to its impact on non-white racial ethnic groups. There's a common misperception that psoriasis is rare in patients of color, which is something that I and I'm sure my colleagues on the panel disagree with. There are also some challenges in diagnosing psoriasis and some nuances to treating psoriasis in patients of color. And these are some of the themes that we're going to be talking about today. So with that, I'd like to start with Dr. Amy McMichael, and I'd like to hear your thoughts on what you think the biggest differences are when it comes to psoriasis in patients with skin of color versus lighter skin types.
Yeah, and I think there's a many, and I think we'll probably get to more than what I could even say today with our other panelists. But one of the big things that I think is missing in a lot of patients with skin of color and psoriasis is the redness. We have brown skin, we're looking at inflammation through the pigmentation of the skin, and so the redness just isn't there. And if that's your cue for psoriasis, then we're going to miss it. So we have to look at the other things. What's the location? Is the location typical? Is it symmetric? Is it scaly? Is it thick? Does it itch the way most psoriasis patients itch? Does it occur in the typical check areas, the umbilicus, which is the belly button, the scalp, in the intergluteal cleft or between the buttocks? If those areas are affected, then we know what we're dealing with. And if at last you cannot be sure, biopsy. I see so many patients that are misdiagnosed because nobody took the time to biopsy them. They treated them like eczema, oh, you have a drug eruption, oh, it's just some irritation from your soaps, and they miss psoriasis. And it's so important not to miss psoriasis because of some of the internal things that we need to be aware of with psoriasis patients. So that's probably one of the biggest differences I think that I see. I think that psoriasis is also a lot thicker.
Yes, and if I can just jump in to piggyback on your point about how a biopsy can be useful to differentiate psoriasis from other scaly or in our language, papulosquamous disorders that can resemble psoriasis. There are many instances where we have a hard time differentiating psoriasis from, let's say, lichen planus, or even sarcoidosis, or various forms of lupus presenting in the skin. So I think that with patients with skin of color, we probably have a lower threshold to do a biopsy because of the challenges in detecting erythema and some of the other visual features of psoriasis.
I agree. I think that if we don't tell our colleagues about this need to biopsy, that they'll continue to miss this. And I think that that's one of the points that I'd like to get out there. I think the other thing that we see in these patients is that they often have thicker psoriasis than we may be used to seeing. And it's chalked up to, oh, well, they're scratching it and it's gotten thicker, or hypertrophic is what we use as the term because of the scratching. And so that's the only reason it's thick, but it actually is thicker in patients with skin of color, more fibrotic, and we don't know why many diseases do that in skin of color patients, but they do. So that's another little trick to treatment, but it also, or to diagnosis, but it also makes treatment more difficult too.
And back to the color issue, the color of the lesions of psoriasis. One thing that I like to emphasize is that don't get hung up on redness, because it may not look red. It might be red-brown. It might be brown, only brown, or purplish brown. And I think a good trick is to calibrate your own eye by looking at the patient's normal skin and comparing it to the involved skin. And then you can get a sense of the difference, and that gives you an indication of how inflamed it is.
Absolutely.
And so you stop thinking about pink and red.
Absolutely, I like that.
Another thing that I notice in my practice is that patients of color with psoriasis, they tend to come to my practice with much more severe disease at the time of diagnosis. In other words, they're walking around undiagnosed for a much longer time, and even if they have been diagnosed, there's a tendency towards under-treatment. I'm seeing patients with moderate to severe psoriasis covered 20% of their body or more, and all they've had is topical therapy and not really been offered pills or injectables or light therapy. So Crystal, can you speak to your experience with deciding about treatments for patients of color?
Absolutely. So, I mean, I think Dr. McMichael brought up a great point. Psoriasis is not just a skin disease, okay? So psoriasis can be a sign of something that's going on internally. So if you have a lot of psoriasis on the skin, oftentimes it means that you have a lot of inflammation in your body as well. And that can manifest as joint pain. So some people may be so used to waking up in the morning with really stiff joints and having to, get their joints moving. They'll say things like that, but that actually is a sign of possibly psoriasis in the joints, or what we call psoriatic arthritis. And that is a destructive arthritis, which means that if you don't treat it early enough, you can have permanent deformities of your hands and your ankles and things like that, and it can lead to permanent disability. And so when I see somebody who has a lot of skin disease, I'm going to ask those questions. Psoriasis also increases your risk of cardiovascular disease, so it increases your risk of stroke and heart attack. So just because as a patient may feel comfortable just covering up those psoriasis spots, they are still at increased risk of heart attack. And we know that if we can get the skin under control, that we may be able to decrease those risk of cardiovascular events as well. And something like a steroid cream is not going to have the same effect internally that something like a pill or an injectable medication would have.
Now, we all know that there have been tremendous advances in the treatment of psoriasis with the development of biologic therapies, and we certainly don't have the time to go through every single new treatment, but would you be able to just give a quick overview of what the latest treatments are and how they've been impactful for your patients?
Absolutely. So biologics, generally speaking, are first generation of medications, and they attacked a molecule called TNF Alpha, which is responsible for a whole host of inflammatory cytokines and things that you get in the body. When you attack something that is responsible for a lot of inflammatory cytokines, you get a lot of side effects. And so over time, newer generation biologics have been developed to specifically target the molecules or cytokines that are responsible for psoriasis itself. So for a lot of patients, I have patients who come in, they were put on an injectable medication that you do either twice a week or once every 2 weeks, and it works very well for them. They don't have side effects. They can stay on those medications. However, there are a subset of patients who have very severe disease who have tried and have not worked for them. So there are newer medications. These medications are more directed therapies.
Thanks for that overview. When I think about psoriasis in patients of color, another aspect of it that comes to mind is that I think the overall impact of psoriasis on many patients with skin of color can be greater in some ways. There are some unique issues that disproportionately affect patients of color. One of them being the pigmentary sequelae. So in addition to the scaling and the redness and the thickness of the plaques, once those are clear, these patients are dealing with months and months and months of light spots or dark spots in the places where the psoriasis was. And that can be just as impactful as on their everyday life as the psoriasis itself. Another scenario where I think there's a bigger burden is when psoriasis affects the scalp, especially among women of African ancestry, like African American women. So Val, can you speak to that particular scenario, which I think has a particular burden?
Yeah, sure. I think when psoriasis affects the scalp in men, it's pretty simple. It's pretty easy. Males of color or men of color like to shampoo their hair every day in the shower. So they can use these keratolytic type of shampoos to exfoliate the scalp and help to decrease those thick plaques. On the other hand, if you have a woman of color who only washes her hair, say, every week or every 2 weeks, to use these shampoos consistently on a daily basis is something that just cannot be done. So I think the number one is to distinguish between seborrheic dermatitis, dandruff, and psoriasis. It's almost like a continuum. And where you have dandruff here and you have psoriasis here and sebderm in the middle. And so that's the degree of scale or plaques or the thickness of the skin in those areas. So you really need to have a keratolytic shampoo. Again, they can take it with them to the salon or they can do it themselves at home. Something that helps to exfoliate those scales. And then you also need to use a leave-on product. So you need to either use an ointment, a lotion, a foam, or solution that contains topical corticosteroids. Sometimes they contain topical vitamin D, And sometimes they're combined, the steroid and the vitamin D. And this is something that's applied to the scalp and left on. And so I think it's real important that we teach them about their hair care, their hair grooming, and incorporate the prescription medicines into their normal routine. And usually that's pretty successful.
One thing I was going to pick up on that you said is the exfoliation of scales. And a lot of times patients will take that to mean, okay, if I scratch these scales up with a comb, this will help. But we know as dermatologists, it adds fuel to the fire. Yes. It's like telling psoriasis, take off, because this is your entry point. And so I always tell my patients, okay, the shampoos or the medications I'm giving you will help with this. You do not need to add any mechanical exfoliation to this process.
Because that predisposes them to infection.
Absolutely.
And also the Kebner phenomenon.
The Kebnon can worsen.
Worsen the psoriasis.
Yes. So that's a really, it's important that they understand the difference between chemical and medical exfoliation and what they're doing at home.
Correct.
Yeah, I like to that point, I like to tell patients, let the medications do their job. You don't need to go and pick off the scale.
No.
The medications will
Absolutely.
That's more harmful to them.
Yes, exactly. And Val, you brought up a good point about a sort of a theme about incorporating our treatments into the patient's hair care routine. And I think that's really important to emphasize. So there are some real nuances to what kinds of products we may recommend for a patient who has braids versus a chemical relaxer versus hair that is straightened thermally. So can you give some tips and tricks of different vehicles, different things different
Sure.
approaches that you take for
Sure. I mean, there's so many
hairstyles?
different vehicles, and I think that's what we do. We listen to our patient. We ask specific questions. What would you like to apply to your scalp? What's the vehicle that you prefer? Because we can use topical corticosteroids that have a foam vehicle that you can just part the hair, take the foam and just apply it. They have even sprays. They even have liquid drops. And so it depends on the hairstyle. So if a woman of color has natural curly hair, sometimes she'll prefer an ointment or an oil to lubricate those psoriatic plaques, those areas. But then if a patient has braids or a hairstyle where the parts are already evident, it's nice to use the liquid drops or a foam just to go right down that braid or that part in their scalp and apply the medication. So I think we just need to ask them, because compliance is important and you want your patients to use the medication, so you have to give them something that they're going to use.
Yeah.
Otherwise, they'll just leave it right
Yeah,
there.
I couldn't agree with you more. And what I like to do is basically involve the patient in the decision.
Right.
Because
Right.
you want to get their input on what's going to work for them with respect to their hair type, their hairstyle, and prescribe something that fits within their daily regimen. And taking that extra step to do that really goes a long way for boosting patient adherence and patient satisfaction.
Yep.
And I actually like scalp oils, the steroid scalp oil as well. And one interesting thing is that if you prescribe a steroid scalp oil, it will say on the box, apply to the hair, sleep with the shower cap, wash it off in the morning. And I tell my patients, those instructions are applicable to patients with straight hair, because if you put an oil on straight hair, it's going to feel very greasy, it's going to feel limp, it's not going to have a nice aesthetic appearance, and so of course they may want to wash it out. But if you have curly hair, you actually don't need to wash it out. It is akin to any other type of hair oil, and so a lot of my patients with braids and extensions like the steroid scalp oil. It's very light, doesn't weigh the hair down, it's very easy to apply, and they don't have to wash it out, contrary to the instructions that the pharmacist may provide to them.
Excellent tip.
Yes.
I
Yes,
agree.
read our instructions, not the box.
Right.
That's right.
That's right, exactly.
That's correct.
Because we're going to make sure that the way they're doing it is going to be helpful for their particular situation and severity index of their disease. Absolutely.
So, of course, we have myriad options for treating psoriasis today, which is a blessing. But let's not forget about some older treatments, some tried and true treatments that have been around for several decades. And phototherapy would be a great example of that. And in my opinion, I think phototherapy still plays a role in the management of psoriasis today. So I'd love to hear your experiences on that. Amy?
Yeah, I do believe in phototherapy. We still have an old school phototherapy nurse, and she gives phototherapy. We've changed our approach over the years. We used to do a lot of Sorolin, which is an oral medication, plus UVA. and certain kinds of UVB. Now we really give only narrowband UVB, and that's sort of an improvement in how we deliver that light therapy. But it has, it's stayed a mainstay of our treatment, especially for those people who don't want to take some of the larger drugs, some of the stronger drugs that we have available, or who can't for various reasons. There's actually a huge trial that's going to be started. It's going to be multi-center. It's going to be all over the nation, where patients can actually join this trial. It's an NIH-funded PCORI grant trial that will allow patients to either come to the center or actually get a home unit for UVB at their home. And that's going to be really a major trial, a way for us to learn more about psoriasis and to treat more patients with something that even the government thinks is important for us to do. And I think that the goal is really to focus on skin of color patients in this trial.
And I think one thing that's important is sometimes patients will say, well, why can't I just go out and tan every day? Why do I need to do do narrowband UVB? Why do I have to have a doctor's orders? And the thing is when you go out and tan, you're not getting, you're getting a whole range of ultraviolet radiation, some of which may increase your risk of skin cancer, which narrowband UVB does not do. Additionally, we're doing very kind of limited doses. We're maximizing effectiveness and minimizing the downsides of sun exposure, because if you get something like a sunburn, especially in patients who are fair skinned, you can actually develop new psoriasis spots on top of that, because psoriasis really loves parts of the skin that have been traumatized in any way. And so while I do love phototherapy, I'll typically say, do it in the wintertime. Maybe in the summertime you can get a little bit of natural sunlight, but we do think that there are specific benefits of medically directed narrowband UVB that you can't necessarily emulate by just doing only natural sun.
Yeah, we still do light therapy, and we think it's very effective, narrowband UVB. But also, it's important that if they're have generalized involvement to do the light therapy all over, but now we have the newer, quote, lasers that give targeted narrowband UVB to specific areas. And so the other areas of normal skin are not affected. So those of our patients who are concerned about total body exposure, we now have these lasers or directed narrowband UVB that we can target certain areas. And we talked about scalp psoriasis. That's an excellent place to have targeted therapy, that eczema laser.
Yeah, great point. Another nuance to treating skin of color when it comes to phototherapy, first of all, we know that hyperpigmentation, post-inflammatory hyperpigmentation, is a common sequela of psoriasis. And we also know that UV radiation can increase hyperpigmentation. So we have to warn our patients and consider the potential risk of worsening hyperpigmentation in our patients being treated with phototherapy.
And also be sensitive to the fact that some of our patients with skin of color may not want to become darker or become tanned. And I think that's an important message for our colleagues, right? To understand that there are some cultural sensitivities there, that when we talk about phototherapy, that we do have to have that discussion with our patients, that this treatment, while completely safe, will make you darker, and it may be temporary, but if patients have to stay on it for a long time, it's important for them to know that, because patients may not be comfortable with that.
Exactly, I couldn't agree with you more. In fact, I include that in the initial discussion about phototherapy in my patients of color, that you may have a darker skin tone, because for some patients that may not be desirable, and that would factor into the treatment decision.
And you can include a sun protection, topical sunscreen or sunblock prior to their treatments.
That brings some advantages to the targeted therapy of eczema laser, as you mentioned, Dr. Callender, as that would limit the exposure just to where you need it and not to normal skin.
Correct.
Yeah.
So, just before we close, any take-home messages that you'd like the audience to know? So, starting with you.
Well, I think our patients have to know that a lot of people do not know how psoriasis looks in skin of color. So again, seek out a dermatologist who has an interest in skin of color, and you will be much more likely to get the right diagnosis, the right amount of emphasis on whether a biopsy or underlying tests need to be done. whether that is tests for autoimmune markers for arthritis or GI symptoms that have sometimes been attributed to the same kind of inflammatory things that are happening in psoriasis. So see that person who's interested in skin of color, and that will set you out leagues ahead if you have a concern or think that you might have psoriasis. And don't give up. You know, oftentimes with psoriasis, we do have to try multiple medications in people with very thick skin disease, and that's what happens in skin of color patients. And so you might have to start at one medication, and what we do is escalate. We will say, okay, that one worked, but not as well as we would like. Let's escalate our treatment to something else.
Like a stepwise approach.
Yes, that's correct. Exactly.
Dr. Agu, any closing remarks?
Yeah, I would just, just to piggyback off that, I would say feel empowered to seek a second opinion. If you've been going to the same doctor for years and they have only provided a cream, you should know that there are so many treatment options available for psoriasis now. There are multiple different creams, there are multiple pills, there are multiple injections. There's really something for everyone. And so you should have a dermatologist who's willing to do that stepwise approach and doesn't say, you're just gonna stick with one thing, because I truly do believe that there's something that works for almost everybody, and it's worth the trial and error to get to that success.
I think you're absolutely right. There's no reason why we can't get patients clear or nearly clear, patients with psoriasis. We have the arsenal, if you will, of treatments that are very effective and safe. Yeah. Dr. Callender, any closing remarks?
So I like the way you said we have the treatment, we have it. And I think patients deserve the best, and they need to be able to have these treatments. And I always think about the patient who came to my office, was a woman, and she had psoriasis from head to toe. And she would tell me that she wouldn't take off her clothes in front of her husband. She was ashamed of the way she looked, and the scales were just everywhere. And she went from doctor to doctor, and no treatments, effective ones, were given to her. And she gave up. And so I think it's important that, we as clinicians, we know that it's important to our patients. We treat them. The quality of life issues for them is very important. And that we actually just listen to them and make sure that we have that empathy and care for them.
Right. I think that one of the things that we do in our society, the Skin of Color Society, is direct people to support. And we can start the process, and we can also get them to the National Psoriasis Foundation, which is one of the best support groups that's in our specialty because of all the things that have been studied and figured out about psoriasis. So patients need to know, even if they're skin of color and they've not heard of this, there are people there that can help you. I myself went to Washington to talk to the Congress people about skin of color psoriasis. I mean, it was a really big marker, and the reason we got there is because of the National Psoriasis Foundation.
Wow.
So it's very important that we recommend them to places where they can get that support.
That's great. So with that, I want to thank our wonderful panelists for this stimulating discussion about psoriasis and skin of color. We've heard about variations in the clinical presentation, differences in the overall approach to treatment, and some of the more burdensome aspects of psoriasis when it affects patients of color. For more information, I welcome everyone to go to the website skinofcolorsociety.org, as well as the National Psoriasis Foundation and the American Academy of Dermatology. Thank you.